welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We have Tessa Vagasky, who is a PGY1 resident at Rush University Medical Center. Today, she will be presenting a journal club on full dose challenge of moderate, severe, and unknown beta-lactam allergies in the emergency department.
All right. Hi, everyone. As mentioned, I'm Tess. I'm currently a PGY1 resident at Rush University Medical Center. And today I'll be presenting on the journal full dose challenge of moderate, severe, and unknown beta-lactam allergies in the emergency department. This was published by Anderson and colleagues in 2024. So starting with a little bit of background, penicillin allergies are the most common allergy worldwide, with about 32 million of these being from patients in the US. And even though this is the most commonly reported drug allergy, the true incidence of it remains low and is less than 10% of those who claim to be allergic. And more than 95% of these patients labeled as having a penicillin allergy can actually tolerate this class of antibiotics. In addition, this allergy tends to resolve itself over time, and about 80% of patients with a penicillin allergy are able to tolerate this class of medications after about 10 years. Another common issue seen with penicillin allergies is that many of these reported allergies aren't even true allergies and are more consistent with what we would consider an intolerance. So looking at the difference between these two, an allergy is a hypersensitivity reaction that is immunologically mediated through either IgE, IgG, or T lymphocytes. And depending on which pathway it's mediated through, this can result in anaphylaxis, angioedema, urticaria, hemolytic anemia, SJS, etc. When comparing this to an intolerance, which is not immunologically mediated and generally includes something we would consider more like a side effect, like GI upset, headache, fatigue, and then these are also harder to link directly to the antibiotic, given that they can be secondary to other disease states or factors occurring at the time of ingestion. So this is just a table that walks through the different hypersensitivity reactions. I'm not going to go through the whole thing, but our type 1 or immediate hypersensitivity reactions are mediated through IgE, and this works through the drug antigen but binding directly on the IgE on allergic cells, which results in degranulation. Generally, we would expect this to occur within minutes to hours after ingestion, and these reactions can include anaphylaxis, angioedema, or urticaria. So this is what we commonly think about when we think of our drug allergies. Whereas type 2 and type 3 are mediated through IgG and work through antigen-specific IgG binding to the antigen on the surface cell to either activate phagocytic or like the complement immune system. Generally, we would expect onset of these to be within days to weeks, and reactions include hemolytic anemia, thrombocytopenia, serum sickness, and drug fever. And then our last one is our type 4 or delayed hypersensitivity reactions. And these work through T lymphocyte receptors binding to drug antigens, which activates macrophages, eosinophils, and then cytotoxic T lymphocytes as well. And again, we would expect onset of these to occur within days to weeks. And this includes our maculopapular rashes and then more serious scar reactions like SJS or toxic epidermal necrolysis. So now that we've established that many penicillin allergies are incorrectly documented, let's discuss why having these listed as an allergy can cause significant effects down the line for our patients. So historically, if a patient had a penicillin allergy listed, many clinicians would be cautious with choosing any of the beta-lactam antibiotics. This includes penicillin, cephalosporins, carbapenems, or monobactams for their treatment regimen due to fear of cross-reactivity between the beta-lactam ring that all of these antibiotics have in common. And this would really limit our treatment options and could result in the use of unnecessarily broad spectrum or inferior antibiotic use, which we all know can be a threat to patient and public health due to increasing antimicrobial resistance rates. And in addition, having a penicillin allergy listed on a patient's chart is also associated with an increased length of stay and then an increase in C. diff infections as well, due to using alternative antibiotics like clindamycin and our fluoroquinolones. So having this allergy listed on a patient's chart is definitely not benign and something we should be actively evaluating for accuracy. So more recently, there's been a lot of interest in looking into what actually causes cross-reactivity to occur between penicillins and other beta-lactams, and if this was really due to the beta-lactam ring or if it was due to something else. So as mentioned previously, the beta-lactam class includes penicillins, cephalosporins, carbapenems, and monobactams. And as you can see in the image on the right, they all share a common structural base that is the beta-lactam ring, and then have different amide bonded R side chains. And you can see the beta-lactam ring highlighted in green here. And then the substitution at these R sites is actually what provides our variation in the spectrum of activity against different bacteria species and allows us to be able to treat a variety of infections with this class. As I previously mentioned, historically clinicians thought that cross-reactivity between the class was due to the beta-lactam ring, but more recently we've discovered that allergies to penicillins and cephalosporins are caused mainly by reactions to the side chains of the molecules and not due to similarity between the beta-lactam rings. So with that being said, cross-reactive antibodies to a similar R1 side chain can cause patients who have a true penicillin allergy to have a subsequent cephalosporin allergy that has a similar R1 side chain. So you can see that in the image here, if the patient were to have an allergy to penicillin and then we tried to challenge them with a similar cephalosporin that had the same R1 side chain, we would expect a similar reaction to occur. And then in addition, patients with a true cephalosporin allergy can have cross-reactivity among other cephalosporins with a similar R1 or R2 side chain. But unlike the rest of the beta-lactams, prospective studies of carbapenems suggest that cross-reactivity is very unlikely between other beta-lactams, and these would be safe to use in patients with allergies. So I won't go through this whole chart, but this is a good representation of how we can utilize the side chains of beta-lactams to say if they would be dissimilar and safe to use in patients with allergies, similar and able to use them with more caution, or identical, and therefore we should avoid their use in true allergies. And of note, you can see on this chart that cefazolin is actually dissimilar to all other penicillins and cephalosporins, so its use is safe in almost all patients with these allergies. And generally, we're comfortable with using structurally dissimilar beta-lactams even in the setting of allergies, because the incidence of allergic reactions when switching to a structurally dissimilar beta-lactam is about the same as if you were to switch to a non-beta-lactam antibiotic. So now that we've discussed when you might be concerned for cross-reactivity between the beta-lactams, let's look at how often severe beta-lactam allergies actually occur. So for penicillins, the incidence of anaphylaxis is rather low at about 0.015 to 0.004%, and the fatality rate is even lower at about 0.002 to 0.0015%. And then for cephalosporins, this is based off of limited data, but the rate of anaphylaxis is about 0.1 to 0.001%. And there's actually a summary of cephalosporin-induced anaphylaxis published that reported cases of anaphylaxis in patients without a known penicillin allergy were about similar to those with a known penicillin allergy. So overall, you can see that the rates of anaphylaxis to both penicillins and cephalosporins is rather low. And then I just wanted to briefly discuss some previous literature that was published before this study. The first one of those being a multi-center pilot study done in 2018 that included 46 patients. Their objective was to evaluate an oral penicillin challenge program for cancer patients with low-risk penicillin allergies. And for their results, they found that all patients tolerated the oral challenge without adverse drug reactions and were subsequently delabeled. The next was a retrospective analysis done in 2019 that included 20 patients that again wanted to evaluate direct oral challenge outcomes for patients with a penicillin allergy. And these patients also didn't develop any immediate or delayed hypersensitivity reactions. 15% of them did develop symptoms, but these were more consistent with an intolerance and not deemed to be a true IgE-mediated hypersensitivity. And just to note, both of these studies did only include patients who had low-risk penicillin allergies. So now getting back to the study we'll be evaluating today. So the authors of the study thought that the overall low rates of severe adverse effects supports challenging the validity of documented allergies with antibiotics that have a dissimilar side chain. They thought that the emergency department would be an ideal setting to challenge these allergies in, since allergic reactions can be identified and treated quickly in this setting. However, current data did not exist evaluating full-dose beta-lactam allergy challenges in patients with moderate or severe beta-lactam allergies. Like I previously mentioned, the only studies were done with low-risk allergies. So the purpose of this study was to describe the outcomes of patients with documented moderate, severe, or unknown beta-lactam allergies challenged with a full-dose administration of a beta-lactam in the emergency department. So moving into their methods, this institution actually had a switch in 2016 where their site's emergency department antimicrobial stewardship program wanted an alternative to penicillin skin testing just because this took a lot longer than direct oral challenges. So they started challenging allergies with full dose IV and then enteral beta-lactam antibiotics in their emergency department. And then through shared decision-making with the patient that included counseling on the low cross-reactivity between the beta-lactam antibiotics, the ED pharmacist or ED provider would determine the most optimal antibiotic regimen. And then for patients who consented to the allergy challenge, a full dose of a beta-lactam was administered without a test dose, regardless of the route they chose. So this was a single center retrospective descriptive study that included patients who were 18 years and older and those who had received a full dose beta-lactam allergy challenge in their emergency department between January 1st, 2021 and December 31st, 2022. They excluded patients who had pre-challenge missing or deleted encounter data, those with mild beta-lactam allergies, and those with documented intolerance rather than a true allergy. The ones they noted in this study were nausea only, or if the patient just stated the antibiotic didn't work for them last time. And then they also excluded patients who had documentation of a previous tolerance to another beta-lactam, despite the recorded allergy still being on their chart. So for their methods, a list of patients treated with a beta-lactam antibiotic in their emergency department who had a documented beta-lactam allergy was extracted from their EMR and reviewed. They separated patients into 3 beta-lactam allergy categories, either moderate, severe, or unknown. Patients were put into the moderate category if they had documented hives, urticaria, or swelling at an unspecified location at a location other than their head or neck. And then they were in the severe category if they had documented anaphylaxis, swelling to the mouth, lips, tongue, throat, difficulty breathing, or shortness of breath. And then they were put into the unknown category if their reaction was listed as unknown or if no reaction was listed under the allergy. And then their data was reported using descriptive statistics. So looking at their results, initially 850 patients were identified with a documented allergy in a beta-lactam challenge, and then they excluded some for several reasons. First one of those being 474 had previously tolerated a beta-lactam. 153 of them had a mild allergy or intolerance, so they were excluded. 23 had their allergy actually removed before the encounter, and then 11 had a non-beta-lactam antibiotic ordered instead, and then 5 refused the challenge or just had a family history of allergy, so it was removed from their chart. So they ended up including 184 patients. For these patients, the median age was 68 years old and about 65.2% of them were female. For the primary ED diagnoses, the majority of them were either pneumonia at 36.5% or UTI at 31.5%. Other infections included intra-abdominal skin soft tissue, sepsis, febrile neutropenia, and meningitis, but these occurred at lower rates. And then looking at a further breakdown of their allergies, so about 90% of the patients included had a documented penicillin allergy. About 13% of them were in the severe category, 42.9% were in the moderate, and then 44% were in the unknown category. So looking at this further, 165 patients had a penicillin allergy, 13 had a cephalosporin allergy documented, and then 6 had both a penicillin and cephalosporin allergy documented. And then looking at the allergic reaction that was documented for each of these, in the severe category, 12 of them had anaphylaxis documented previously. This was 11 to penicillin and then 1 to cephalosporin. 6 of them had swelling of either their mouth, lips, throat, etc. And then 6 had difficulty breathing documented. For our moderate category, 68 of them had hives or urticaria documented, and then 11 had swelling at a location other than noted above. And then 81 patients had an unknown allergy documented. So looking at the different antibiotics that they challenged these patients with, the majority of them did get ceftriaxone. This was 83.2% of them. The next most common one was cefepime at 10.9%, and then others included cefuroxime, piperacillin tazobactam, and then 1 patient got cefazolin. So of those with a previously documented anaphylactic reaction, 0% actually developed an allergic reaction to the beta-lactam challenge they received. And of those that did develop an allergic reaction, this being 5 patients, only 2.7%. 2 of these were to ceftriaxone, 2 were to piperacillin tazobactam, and 1 was to nafcillin. And nafcillin wasn't listed on the previous slide because it wasn't initially given to the patient in the emergency department, and they were actually switched to it once they were admitted and ended up having a reaction that And then of these reactions, 4 developed a rash and then 1 developed itching, so nothing super severe, and no patients experienced anaphylaxis. And each of these reactions occurred within 72 hours of admission with a median of 3 doses of the beta-lactam prior to the allergic response occurring. So moving into our discussion. So only 2.7% of the included patients developed an allergic reaction after full dose beta-lactam administration, which further demonstrates that beta-lactam cross-reactivity is low and that direct challenge of these allergies in the emergency department can be a safe and effective way to reduce unnecessary avoidance of beta-lactams in the penicillin allergic class. For strengths and limitations of this study, limitations included that it was a single institution study, so it limits our external validity, and that ceftriaxone was mainly what they challenged with, so it's hard to justify that the other beta-lactams are going to be as safe for use in these challenges, just because we don't have as much data to justify that we wouldn't see an increase in adverse effects with these. Strengths included that they did include patients with moderate to severe allergies, so more of our higher risk patients. I think this is a big strength because previous literature had only really included patients with lower risk that we wouldn't get as worried about challenging these patients in. And then they did see an overall low rate of adverse drug reactions, so this further validates that challenging these patients' allergies can be safely done. So now I just wanted to briefly discuss some other important points when dealing with penicillin allergies that weren't discussed super in depth in this study. The first one of those being proper documentation of the beta-lactam challenge we just did. So in the study, they did mention that the stewardship team updated the allergy profile with what beta-lactam was challenged, the outcome of the challenge, and the date it occurred in the EMR of about 74% of its patients, which is a good number, but I think it could be improved just because I think this is an important step in the process of allergy challenges for several reasons. The first one of those being that it reduces initial chart time review process if the challenge was properly documented. I know from my experience working with these patients, it's very helpful when you see a patient come in with a penicillin or cephalosporin allergy to see all the other beta-lactams they've tolerated in the past and see that pretty quickly. It just reduces time to choose an empiric regimen for them. And then this ultimately will reduce fear of cross-reactivity between the beta-lactams because if other clinicians can see that they've tolerated different beta-lactams previously, they'll be more willing to give them those in the future. And then this just in turn expands our antibiotic regimen options, which is always a good thing, and then avoids rechallenging with the same antibiotic, saving us and the patient time. So this is just a screenshot at the bottom of this slide of what this might look like in EPIC. So you can see that this patient had a penicillin, amoxicillin clavulanate, and then vanco allergy. All these were pretty severe, being anaphylaxis or angioedema. And then you can see that it was properly documented that they tolerated ceftriaxone in December of 2023. So this is really easy to access on their chart, and then they can choose an empiric regimen pretty quickly for them. And then I also briefly just wanted to discuss when we're actually able to delabel a penicillin allergy. And this is specific to my institution, so yours might be a little differently, but at Rush, we're only able to delabel the patient for 2 reasons. One being if the reaction was non-allergic. So if they had more of an intolerance documented, like GI upset, nausea, or if they just had the penicillin allergy documented because their family has a history of it, you can remove the penicillin allergy from their chart for those 2 reasons, or if the patient has tolerated amoxicillin or ampicillin in the past. So none of the patients in this study that they challenged with other cephalosporins would actually be able to have their penicillin allergy removed, but I think proper documentation of the challenge is still important. And then it's always important to counsel the patient on the removal of the allergy, because we wouldn't want to go through all of this work and challenging the patient just for them to go to a different institution or their PCB and then have the allergy just added back on and have to redo it all. And then the study didn't mention when to avoid challenging penicillin or cephalosporin allergies, so I just wanted to touch on that quickly. Generally, drug challenges are contraindicated in our more severe non-IgE mediated reactions, such as our SCAR reactions, drug-induced liver injuries, or drug-induced cytopenias, just because we have limited data on challenging these patients and they are higher risk for severe reactions. So we're still unable to do beta-lactam challenges in them without an allergy or an immunology consult. So in summary, penicillin allergies are the most commonly reported drug allergy, and fear of cross-reactivity between beta-lactams can result in the use of unnecessarily broad spectrum or inferior antibiotics. And given this study, direct allergy challenges in the emergency department can be a safe and effective way to reduce unnecessary avoidance of beta-lactams. and it's always important to properly document that the challenge was tolerated, the date it was tolerated, and then it's always important to remember to remove that allergy label when you can do it. And I just want to give a big thank you to Giles for his help with this presentation, and I'll take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.